Hi, everybody. I'm Eddie,
I'm Ashwin.
And I'm Raj.
and welcome to Blood Cancer Talks. This is a podcast, as you know, dedicated to hematologic malignancies, where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and in clinical management. Today, we're going to discuss the use of circulating tumor DNA, or ctDNA, in B-cell lymphomas, especially in DLBCL. And we're delighted to have two guests with us today. The first is well known to our podcast audience, Dr. David Russler-Germain, who is a lymphoma clinician scientist from the Siteman Cancer Centre and Washington University in St. Louis, and who joined us for our ASH Roundup episode last year. Welcome back, David.
Thanks, Eddie. Nice to be here.
And our second guest is a giant in the lymphoma world, Dr. Alizadeh. Dr. Alizadeh is the Moghadam Family Professor of Medicine, Oncology and Hematology at Stanford University and leader of the Cancer Genomics Program at Stanford Cancer Institute. He's led a lot of the work around understanding lymphomagenesis and lymphoma genetics, and in the last 2 decades has been a pioneer of different ctDNA techniques, which we're going to get into a lot today. But before we get to the topic of ctDNA, Ash, first, could you tell us a little bit about yourself and your journey to becoming a lymphoma clinician scientist?
Sure. I'm a medical oncologist and a lymphoma-focused clinician, but largely focused on um, the science of lymphoma biology with a translational focus and a focus on genome technologies. I did my undergraduate work at UCLA and then came to Stanford a little more than 30 years ago, where I started med school and my MD PhD work. I was fortunate to be in a lab at kind of the dawn of the genome era and apply some early genome technologies to lymphomas, and kind of got lucky in finding some disease biology and diffuse large B-cell lymphoma, and that kind of paved my path for the future, my future in being passionate about lymphoma biology and genomic technologies and kind of the broader use. I've been on our faculty for more than 17 years now, and that's it.
Yeah, so you like it where you are, and you've sort of grown up there and flourished, which is nice. So now I know we could spend a whole podcast talking just about genetic heterogeneity of B-cell lymphomas and DLBCL, but I do think it is important, before we jump into talk about ctDNA, to talk a little bit about that. So Ash, could you first sort of set the stage to introduce us to what we understand about the genetic heterogeneity of B-cell lymphomas, to sort of preempt some of the discussions we'll have about different ctDNA mechanisms?
Sure. So if we focus on the most common arguable blood cancer, large B-cell lymphomas, you know this to be a disease of tens of thousands of Americans each year, the majority of whom we cure with modern induction regimens that combine a number of drugs and immunologic agents. But we don't cure everybody, and people have been trying to understand the underpinnings of this from many different views. But one of those views is the genomics of the disease. And when you talk about genomics, you talk about the DNA, the RNA, and various aspects the genome manifests itself. But it is a sobering landscape to look at in terms of how different each patient's lymphoma is from another, when considering the set of mutations that are present, when considering the genes that are expressed, and how those phenomena affect the behavior of the disease. And so over time, we've learned how to find little lumps to kind of take a bigger disease and make it into smaller groupings. But by and large, those exercises have produced prognostic, not necessarily clinically directive, actionable information for treatment selection, so to speak. So we have a ways to go to catch up to some of our sister diseases where that's more refined with precision guiding of treatments.
All right. So, David, next, can you explain what is the need in lymphoma for novel biomarkers like ctDNA, for example?
Yeah, so I think there's several real areas of need in lymphoma biology for both pre-treatment and post-treatment molecular testing, and that can encompass a range of things. Pre-treatment, as Ash was getting at, DLBCL and many other lymphomas are heterogeneous conditions, and unlike many solid tumors, and I think non-small cell lung cancer is a good example, where there's often a singular genomic driver event that needs to be targeted often with a tyrosine kinase inhibitor, for example. Lymphomas have complex genomic profiles, and pathways are often implicated, involve chromatin modifier genes, et cetera. And what that means is that personalized medicine is going to be more than pairing a patient with a given mutation to a given drug. It's more of phenotype of disease to drug rather than genotype of disease per drug, if you get what I'm saying. And so as we move towards hopefully personalized medicine in DLBCL and other lymphomas, having really comprehensive genomic profiling of the disease, not only to survey mutational landscape, translocation, structural alterations, but also, in essence, the expression profile of the disease, what features of the microenvironment or gene expression phenotype of even the malignant B cells might best pair with certain therapy. Markers such as, or tools such as ctDNA, I think, are going to be poised to be a sort of one-stop shop for all of that information. Without going into too much detail, I think pre-treatment plasma ctDNA testing can give us tumor genotype in DLBCL, as Ash's work has described over several years, and hopefully also sort of the gene expression landscape in a surrogate format in that respect as well. And that all goes without saying that after treatment, PET scans, as we'll get into a little bit today, are imperfect response assessment tools in many lymphomas, especially DLBCL. And measurable residual disease testing is something that ctDNA is really going to excel at, I think.
Yeah, so Ash, MRD, or measurable residual disease, as David just mentioned, has been around and pretty widely implemented for acute leukemias, for CLL, and for myeloma for many years. Why is it so much harder for us in lymphoma to assess lymphoma using a blood-based biomarker?
That's a good question, Eddie. We could argue how widespread MRD is for the diseases you mentioned, but you're right, they've been around for a long time. CML, acute leukemias, and more recently CLL and myeloma, at least in the drug development area, not maybe less so for actual routine workaday care of the patients, has been around for a very long time, in part because the ways in which those, molecularly detected, but, radiographically occult or microscopically occult disease burdens could be found were relatively simple, straightforward, and democratizable across institutions with some assays that could be implemented. For lymphomas, I think that's been harder to get to, in part because where the disease tends to hang out, especially for the nodal or extranodal diseases that don't circulate in large numbers, has made, cell-based assays like what we depend on for myeloma with the bone marrow, or circulation for CLL less applicable. So, for example, when we first started, we began applying a method called immunoglobulin high throughput sequencing. At the time, it used to be called the clonocyte assay, now the clonoSEQ assay. That's immunoglobulin rearrangement-based cancer detection. And we tried monitoring a group of patients with diffuse large B-cell lymphoma. This is 12, 13 years ago. When we first started, we noticed that it could work, and it was really good at the positive predictive value, but not so great for the negative predictive value. A significant fraction of patients that recurred were MRD negative. And then we applied that same assay both to blood cells that hematologists are so enamored with, and to cell-free nucleic acids, to cell-free DNA that's in plasma. And we were surprised that both qualitatively and quantitatively, you could get better performance in cell-free DNA than cellular compartment. And that kind of makes sense if you think of the fact that you can't really rely on flow cytometry to detect, say, DLBCL very well, the way you depend on it for leukemias. And whereas for cell-free DNA, in the same way as, let's say, a prenatal diagnostic works to find aneuploid fetal cells in mom circulation at a few weeks of pregnancy, when 10, 20% of the cell-free DNA may be fetally derived, there's not 10, 20% of the cells in mom's blood that are fetally derived. So you leverage that. So that same idea worked by immunoglobulin sequencing, but those methods were not sensitive enough. You could not Immunoglobulin sequencing has an analytical technical limit of detection on the parts per million range when you have 1,000,000 cells worth of DNA. But unfortunately, in cell-free plasma, you don't have 1,000,000 cells worth of DNA. So you could not achieve those technical limits. And the competing methods to try to get that lower limit of detection have been evolving over the last decade and not routinely available to hematologists and oncologists or applied in large groups of patients to transform the field. I would think that's part of the reason that it has been less transformative.
So, David, to you, as Ash was mentioning briefly about clonoSEQ, so it is one of the earlier successful approaches to trying to assess lymphoma MRD is the clonoSEQ. Maybe, David, for our listeners, can you explain how clonoSEQ works and what are the advantages and disadvantages?
Yeah, so the clonoSEQ assay is currently commercialized by Adaptive and is essentially it's a next generation sequencing assay of a piece of PCR products around immunoglobulin heavy and light chain genes. And so you need a pretreatment specimen, some marker with the tumor to identify the trackable clone for a given patient. Sometimes it's actually a little more challenging because there can be several heavy and or several light chain clones that are detected in a specimen and you're trying to pick one, or the companies are either trying to pick one to use. And then you're essentially using either a cellular fraction like in CLL, ALL, or mantle cell lymphoma, extracting the DNA and making a PCR product around immunoglobulin heavy light chains to perform sequencing on, or as they've recently commercialized for DLBCL, they have a plasma-based immunoglobulin sequencing assay from the ctDNA fraction. Now, the biggest downside to this approach is that you're really looking at one target. Essentially, even if there are multiple BCR clonotypes that were identified as clonal in the diagnostic biopsy, the post-treatment MRD assessments are all based on a single dominant clone from the first sample being then tracked in the relapse specimens. And so for a variety of reasons, that may not be the most accurate way to assess someone's disease burden for a number of reasons. One is there is occasionally switching of the VDJ component that the B cell receptor may have. There may be loss of a part of that chromosome, and then it's not detectable from an artifactual reason, but also simply just from a molecular testing perspective. And Ash will talk about this, I'm sure, as we get into sort of targeted panel MRD assays. But when you're looking for one molecule, like one site in the genome as the thing you're trying to track, how sure you are that the cell that gave rise to it is not there, you can lose your confidence very quickly when you're only trying to find one thing.
David, I had a quick follow-up here. So we use, as you know, clonoSEQ a lot in myeloma. To my knowledge, there is no published literature on the cells switching their VDJ sequence. Maybe it happens and we just haven't seen it yet. But would you think that there is some fundamental biological difference between lymphoma and myeloma, or do you think this can happen in myeloma too, like switching and a clonoSEQ missing a new clone that has emerged, let's say?
Yeah, I think it just speaks to where in B cell or lymphoid in general maturation the disease cells come from. It's certainly not common, but I've already, in my short attending clinical practice, taking care of 2 patients whose relapsed lymphomas had overlapping like somatic variants that we went to the length of proving, but had light chain switching. So like was kappa at diagnosis and lambda at relapse, or vice versa. And so I think just the fact that the cells can actually undergo, like if you had an IgM like disease especially transformed lymphomas, then the recurrence doesn't always keep the same immunoglobulin gene. I love Ash's intake on that too.
Yeah, it's true. In immunology, that's called light chain editing. So that was discovered about 20 something years ago. So the light chain can switch. The heavy chain can also switch a significant minority of the time. And David Scott, the Hilton JCO paper, where they looked at the kinetics of early versus late relapse, they showed that a significant minority of late relapses actually can switch V and J as well, suggesting, where in the B cell, in the developmental hierarchy progenitor may lie. But you're right. Raj, that most lymphoma recurrences share the original clonotype as defined by VDJ. So if you know about Waldo based on VDJ, heavy chain, in particular, light chain less so, it tends to stay the same.
So you set out just before, Ash, a nice sort of path for the next few questions we want to ask you just before. So clonoSEQ obviously still used, and we talked with David after Ash about the data in sparing patients in MRD negative CR with mantle cell lymphoma transplant based on clonoSEQ. Since clonoSEQ sort of came about, you and your lab have come up with some different ways of trying to get more sensitive and specific approaches to measuring ctDNA. So can you, so sort of next in that, or one of the next steps was CAPSEQ, which was stands for Cancer Personalized Profiling by Deep Sequencing, or CAPSEQ. So could you explain to us a bit how you came up with that and how it works, and sort of what its advantages are over clonoSEQ?
Sure. So this idea of finding a tumor marker that you monitor, whether it's immunoglobulin, heavy chain, light chain, or other somatic mutations, defines a whole class of tools that we call tumor-informed cancer monitoring tools that can apply to the cell-free or cellular compartment. But as we both talked about, there are limitations to using a single gene, whether it's that gene, if you want to find Waldo and you know only what Waldo looks like by the fact that he wears glasses, that may only carry so much information. But if you want to know more about Waldo with a striped shirt and, the et cetera, that gives you more shots on goal for finding him in the crowd. And that concept, if you apply to genetic mutations, can be applied both in solid tumors and lymphomas. And CAPSEQ was one such approach where we said, instead of just focusing on immunoglobulin heavy and light chains, we'll focus on the suite of mutations that are known to be most pervasive and prevalent. Find the part of the genome, the smallest part of the genome, in whom you can maximize the number of mutations in the average patient. So we target a few hundred genes, a few hundred kilobases, and those are the business end of the cancer genome for the average B-cell lymphoma. And we go capture that, and we find the mutations in a given patient using their tumor biopsy or pretreatment blood sample to find the mutations and then track those. And that was what CAPSEQ was. And then there was some technical refinements to that method, and we applied that to lymphomas, and it had significant advantages in the cell-free compartment for cancer monitoring because we were following hundreds of mutations instead of one or two mutations. So if you have a few thousand cells worth of DNA and a few hundred mutations, multiply those two, now you get into 1 in tens of thousands of cells kind of limits of detection instead of 1 in 1,000. So you get better and better at doing this. And so, but we were still finding that the tests were not super good at the particularly difficult clinical milestones. Say at the end of treatment of diffuse large B-cell lymphoma, once a patient is in a radiographic remission and has finished their treatments, the vast majority of patients were negative by CAPSEQ at the end, just like they were negative by clonoSEQ. So we had focused on early dynamics, but at the end of treatment, we were reaching limitations. And then this same approach, of course, sister diseases, like the solid tumors, are used to using other tests like Signatera from a company called Natera, where they do whole exome sequencing and find 16 mutations to track a breast, lung, bladder, colon cancer, for example, in the MRD setting for disease tracking.
And what proportion of patients have a kind of sufficient sample to be able to be trackable by this sort of technique?
So in diffuse large B-cell lymphoma, it's the vast majority. So it depends on what you mean by trackable. If you mean to find a single mutation, it's close to 100%. If you're talking about finding hundreds of mutations, depends a little bit on the histology. So the somatically mutated germinal center-derived lymphomas like follicular, Burkitt, large cell, et cetera, will do quite well. So, but the less germinal center experienced tumors, like a subset of mantle cell lymphomas, a subset of CLLs, Richter's transformation, will not have hundreds and hundreds of mutations in a few hundred kilobases. So that limits the applicability. So just like a PET scan is probably less informative in a marginal zone lymphoma than a mantle cell lymphoma, these same assays have the same limitations on context, and we're learning how those limitations affect their clinical use.
All right. So more recently, your group built on the success of CAPSEQ and created this new technology called PhaseSeq. So how does PhaseSeq differ from CAPSEQ, if you can tell for our audience, and what are its clinical uses?
So CAPSEQ, as I mentioned, looks at individual point mutations. So let's say you're used to a mutation in KRAS in lung cancer or MYD88 in lymphoma or CD79. And those mutations are called single nucleotide variants by and large. They're individual mutations on individual DNA fragments. And one of the tricks that we often play is a method called duplex sequencing, where we leverage the fact that mutations that are found in both DNA strands, the Watson and Crick pairs of a given DNA strand, are much less likely to have occurred randomly by the polymerase chain reaction that we do in the tube or by the sequencing machine. They probably happened in the person and were replicated then. So that idea was introduced by a group from University of Washington a little bit more than almost 15 years ago for ultrasensitive genotyping. And we applied it within CAPSEQ and it works quite well. The problem is only about a third of molecules we could find the duplex. We could find the sister molecule. If we found Watson to find Crick, so and vice versa. So we couldn't find this thing. And the idea was, well, if we could look across molecules in trans, what if we could look within molecules in cis to find two mutations that instead of going, KRAS on both Watson and Crick or MYD88 on both Watson and Crick, what if we had MYD88 L265P and a sister mutation nearby? And that little bit of insight there was the magic insight that we have. And a student in my lab, David Kurtz, as a bioengineering student, took that kernel of an idea and kind of ran with it and developed a strategy and really leveraging the biology of B-cell lymphomas and what the mutation signature of these tumors looks like. So B-cell lymphomas, because most of the time have gone through the germinal center, have experienced what immunoglobulin experiences, the process of affinity maturation and somatic hypermutation, not just of the immunoglobulin gene, Eddie, but the rest of the genome, where a lot of these mutations cluster in an intergenic region. So we took the CAPSEQ concept and then instead of doing single nucleotide ideas, we said we'll focus on phased variants across a much larger part of the genome. And by doing that, we said, okay, first, can you find such things? So if we look at whole genome sequencing, are there enough of these? And in B-cell lymphomas, it's amazing. It really, they're all over the place. So you can find hundreds to thousands of these in the average patient's tumor genome, and you can define a small space to find them in. But then the next question was, okay, if you can do that, can you find less error so that the errors that we introduce out of the patient's body in the laboratory by errors of the polymerases or the sequencing machine, can we make those go away by focusing on these cis mutations? And in fact, you could, and now you could get to parts per million instead of parts per 10,000 or so performance. And that kind of insight was valuable for building this method. And now we're learning how the application of that method can help us overcome the limitations of the prior methods.
So just to pardon the pun, recap, you're talking about sequencing sort of hundreds of different spots for CAPSEQ. How do you approach that how much of the kind of genome of the, are you again picking hotspots to look for the phased variants, or are you looking through the whole genome when you're looking for phased variants?
So that depends, Eddie, on the clinical application. In the B-cell lymphomas, if you do a whole genome sequence and you say, are there phased mutations, more than one mutation that fall in close proximity, so that if you find one, you're likely to find the other nearby and leverage the cis error suppression, they're all over the place, and they form this very striking landscape in what we call these Manhattan plots, a skyline of the mutation genome. And you can pick those regions such that if you target a few hundred kilobases of the genome, you can find hundreds to thousands of these in the average patient. For other tumor types, let's say breast cancer, lung cancer, you don't get the Manhattan skyline. You get the Mojave Desert.
St. Louis skyline.
Yeah, St. Louis skyline. There you go. You get much sparser landscape. So instead of being able to use an off-the-shelf panel for each patient on average, you have to customize the strategy. So we begin by doing a whole genome sequencing, define Waldo, and then make a custom panel for each patient that we monitor.
One thing I'd add is that they had the insight to not rely on the fact that the mutations did or didn't have to be pathogenic, because these don't all have to be drivers of the pathology. And the key is you have a barcode of the disease because of the phased variants, but they could be silent. They don't have to change they don't even have to be in protein coding space, let alone actually impact the amino acid sequence. And so I think getting our minds past tracking pathogenic variants was a huge conceptual advance.
Yeah, I think that is true. It's also, I was surprised that how many of these are now being found to be, even though they're not coding, to still have functional impact. The group from Columbia, Ricardo Della Favra and Laura Pascalucci's lab, have shown that some of these are, even though you would predict them to have no function, can have crazy functions that dysregulate things. So, but you're right, they don't have to have function. As spots on the dog, they're still useful for tracking the dog.
I want to ask Ash next a bit of a slightly off-piste question, but related to what you've just been talking about, which is, Ash, obviously you've been part of founding Foresight Diagnostics, a company, and so which to kind of grow phase-seq commercially. So I wanted to ask you, how have you found that experience, and how do you balance it alongside your academic and your clinical work?
Yeah, so I grew up at Stanford during a time where industry academic relationships were particularly tense, and a lot of anti-industry concepts I learned while I was in Pat Brown's lab around the democratizing access to techniques and information, and relying on the cancer genome to. But as I got older and went through my clinical training under Ron Levy's mentorship, I learned that you really can't see this as a zero-sum game, and that it be one or the other, that really you rely on industry for translating ideas and technologies for our patients. So with our first method, the CapSeq method, we ended up founding a small company that was quickly acquired by Roche, and Roche really brought the CapSeq method to the market, and is now a clinically available diagnostic assay for a number of applications. But with a model around selling kits to diagnostic labs. And I saw that path as kind of slow and long and kind of difficult to replicate again. And so we decided to try something different, which is to start our own company and really push the ideas as hard as we can ourselves within a centralized lab framework. So a talented graduate student from the lab from Colorado, Jake Chabon, ended up, once leaving the lab after doing his PhD and postdoc work, going back to Colorado and starting Foresight Diagnostics about 5 years ago, and building a large CLIA lab there, all focused on trying to bring this technology for patients with lymphoma and also for solid tumors. And the company's grown quickly to over 120 or so odd employees, and really doing huge operations now across a range of things. It's been sobering for me, as the company's founder, one of the founders of 4 founders, and to see that process and kind of the growth of the company. But we still have to put the ball in the end zone. We're far away from it, right? I took some time while I was on sabbatical to kind of lead the medical operations there a couple years ago. But we'll see how the company does. I'll be excited to see how it grows.
Now, shifting gears to discuss some of the clinical data looking at the efficacy of phase-seq as an MRD biomarker in DLBCL. So, to David, to you, at last ICML meeting in 2023, Mark Rojavsky presented some data that looked at 115 patients pooled from across a few different small frontline DLBCL clinical trials. Already in that study, already after 2 cycles of R-CHOP, some patients were ctDNA negative, and by the end of treatment, 70 out of 93 patients accessible were ctDNA negative. So, David, how did these results go at predicting patient subsequent outcomes?
This was really a nice study that Mark Rojavsky from the NCI presented that, like you said, took patients on a variety of clinical trials, all getting anthracycline-based induction treatment for, I believe, advanced stage DLBCL, ranging from the NCI, Stanford cohort, and other academic centers. By and large, I think this showed us how much better MRD testing is at both prognostication than PET scans. And so end of treatment ctDNA positivity by the phase-seq assay had roughly 90% sensitivity for predicting subsequent PFS events. And essentially flipping it around, 97% of patients who are MRD negative at end of treatment, at least at the roughly 1.5-year follow-up landmark, remained free of progression. And I would use those numbers to contrast with the published PET literature. And so I like to cite 2 studies, I think, that give the upper and lower limits of how informative end of treatment PET is in DLBCL. And so in the Goya study, which compared R-CHOP to obinutuzumab CHOP, roughly about half of the patients with end of treatment positive PETs were actually cured, meaning they had 5-year PFS. They were PFS free. And so that's sort of saying in the best case scenario, a positive PET is giving you a coin flip as to whether you're going to recur. Whereas conversely, what I would view as the worst case scenario of interpreting PET, the Alliance 50303 study showed that if you have an end of treatment positive PET, you might only have a 20 to 25% chance of actually recurring. Now, those numbers exclude truly primary refractory patients who are growing mid-therapy, of course, like they have not had progression on their frontline treatment. But I don't think anybody needs MRD or a PET to tell them that their patient is growing on R-CHOP. The clinical acumen tells us that. But for the patients who've responded to therapy and get to a post-cycle 6 PET scan, personally, I would probably rather have an MRD test based on its current performance than a PET scan if I had to pick between the 2. That's just me.
So David, going back to the data that you showed, I mean, it's really impressive, the difference compared to PET. And I will say that where it's not ctDNA, of course, but with clonoSEQ in myeloma, we are seeing similarly. We think that imaging may not be as important as a part of the MRD once we have that clonoSEQ assay. Now, Ash, to you, the next question. At ASCO this year, Stephen Wang from Amsterdam presented data on 150 patients from the HOVON 902 study, looking at the prognostic significance of MRD by phased-seq at the end of treatment after frontline treatment of DLBCL. Could you tell us the top-line results of the study and what are its clinical implications?
Sure. So the prior studies that David mentioned from Mark Rojavsky were frontline academic studies, investigational studies of augmenting upon anthracycline-based induction regimens with curative intent in large cell lymphomas, mostly focused on advanced disease with a minority of patients with early stage disease. And there were some pretty striking Kaplan-Meier curves from that work. But of course, this was limited to, single or small multi-institutional studies and experimental therapies. It wasn't vanilla R-CHOP in 4 out of the 5 studies being considered. So could there have been some heterogeneity in those things? And so there have been a couple of studies that have tried to look at that in just more real world settings. One was a study by a group from Samsung Medical Center, a Korean study of a similar population of patients, where at a single institution, the flow of patients with large B-cell lymphoma, consecutive patients, were monitored with FACESeq, and they had some pretty striking Kaplan-Meier's, not quite as striking as the Warshawski study, but still pretty dramatic and independent information beyond the PET. So the study by Stephen Wang and colleagues reflects on a Dutch-Belgian national study with the intent to monitor with ctDNA in prospective fashion curative intent therapy of large B-cell lymphomas, including mediastinal and high-grade B-cell lymphomas, and looking at the real-world performance in that population. Patients were genotyped. Waldo was caricaturized by looking at the tumor biopsy or blood plasma. When tumor was available, tumor was used. When plasma was available, plasma was used. And when they were compared, when both were available, they were quite concordant. But the striking observations were the clinical performance in both patients with PET remission at end of treatment and patients in PET partial response or stable, less than a remission. Both populations were dramatically stratified by Kaplan-Meier's using MRD in this population, and that MRD positivity strongly anticipated future progressions, especially for the patients that recurred within a year. If the patients progressed much later than a year, the performance actually degraded. So that suggested that for late recurrences, you can't bank on a single assessment at the end of treatment. You probably need something like what we're used to doing for remission confirmation and verification over time. You probably need one a few months later, and there's subsequent studies now using the same population to monitor. So yeah, the statistics were about a quarter of the patients, similar to the Warshawski study and the Samsung study, MRD positive at the end of treatment, and the hazard ratios were above 10 for PFS and OS for MRD positivity. So pretty striking if you think about the typical hazard ratios that we're talking about. So really, Kaplan-Meier's that have giant separations between the positive and negative patients. And again, doing that in the overall population, but also independently of PET. So I feel like a study like this, if I had, as a patient, a gun to my head to choose between these two, if they were available to me, it's a no-brainer. A coin flip test, as David suggested, is not as good as one that is as discriminatory, though this is not part of our standard remission assessment criteria right now. So I think we need to be thoughtful the way that myeloma and CLL have been, and ALL has been, and CML has been in lymphoma, and say, okay, here's the wealth of evidence. We don't have a randomized trial yet that uses this information to make directive measurements. But if the end of treatment remission assessment is better with one method than another, does not expose you to radiation, is available, and it's doable, should we be considering that as the better way of assessing a remission? But we'll see how our community thinks about this idea after ASCO.
So, David, do you think that, that there are a couple of other studies that Ash's group, that Mark Reshevsky's group, some from the Germans as well, using this technique in clinical practice? Do you think we have enough data, enough numbers of patients to start applying these in clinical practice? Are there situations where you've started outside of, I know you've got ctDNA built into many of your clinical trials, but are there situations where you've started to use it in standard practice yet?
I mean, we have the adaptive clonoSEQ plasma-based PCR clonotyping assay available clinically, and I have, in the last 2 years, had 2 patients who I felt it would be better than nothing to adjudicate confusing end-of-treatment PETs. That's not to say that there aren't major limitations of the assay, but and as well that I don't have long follow-up of my 2 anecdotes to say what actually happened, but it was something to do that beyond just either a super risky biopsy, that would probably have a high false negative rate, but also beyond, sometimes negotiating with insurance for a follow-up PET is a challenge, where they say, oh, you can, some I've taken care of patients who say you can only get 6 PET scans in your entire life. Use them judiciously, something like that, irrespective of how many lines of therapy somebody needs. So in that case, any information is better in my perspective. And so I think if we have access to, as the NCCN guidelines have said now, 1 part per million MRD-based assay in DLBCL, I think, the only downside to implementing that in the real world is really twofold. One is there's some cost associated with it, but I would add that doing pre-treatment and post-treatment MRD assessment costs less than 1 dose of any of the biologics we give multiple doses of to these patients. And second, I think we just have to be wary to avoid over-treatment for patients with no detectable disease on PET, but MRD positivity, because we don't have the evidence of what to do to intervene at that stage yet. They could have residual low-grade lymphomas that don't need intensive therapy. There are a lot of nuances to that, but that, I think, dovetails well with the trials that many of us are inspired to run moving forward to improve the outcomes in that situation.
Just to follow up to your last comment, David, is there much data on the ability of, or how frequently, or how well these assays work in patients with transformed lymphomas?
I think Ash will know the answer better than that. I think we know that there are several examples in the literature of people who have treated transformed lymphomas, and what emerges at relapse when having been MRD positive before their relapse was probably their indolent clone all along. I don't know population level, like any statistics. Do you, Ash?
I don't, and honestly, most of the studies that I know of did not exclude transformed follicular lymphomas, unlike many of our prospective clinical trials have. So that for the MRD-focused studies, a significant minority of the patients who are MRD positive but who don't progress with aggressive large cell lymphomas, the question is, are you seeing the indolent lymphoma, and is that information valuable? Because at the moment, these assays can't tell you if the detected disease is indolent or aggressive. I imagine someday we will, with sister assays that kind of adjudicate the positive as is it FL or is it DLBCL, but they don't exist yet. I would anticipate that the positive predictive value of an MRD test at the end of treatment of TFL might be less good for DLBCL than, a de novo large cell lymphoma without any antecedent FL. But I think the question is whether knowing about that FL still matters, right, for other maneuvers that you might try.
So, looking at sort of where things are at in terms of what data we have so far, Ash, what do you think the path is to get from where we are now to a kind of data to inform a wider use of ctDNA?
Yeah, I think it's just in seeing at our sister diseases how diagnostics have evolved. It seems like the burden of proof is much higher than, say, when PETs were first used or CT scans were first used, even though, I don't know, I just learned this a couple days ago. How many CAT scans we use in the US per year is, what would you guess is the number of CAT scans per year?
A couple of billion, I don't know.
Yeah, it's about 90 million a year for about 60 million Americans. So about 1 in 5 people gets a scan once a year. That's not just cancer, right? That's just, they're incredible tools, but we use them with very few randomized trials showing that they have, because of first principles, they measure disease. And I think liquid biopsies have the same ideas behind them, if they're good studies to show that they measure disease the same way as we use paraprotein to monitor myeloma, et cetera, that we should be thinking about using them. But the 2 places in which we can build the clinical evidence are use of these biomarkers for patient selection, the way a companion diagnostic would be. For example, are patients who are MRD positive at the end of treatment, who are not in a true remission, better served by treating that low burden disease with emerging therapies like those that rely on immunity CAR T cells, bispecific agents, and there are a number of clinical trials in that vein right now, randomized registrational studies where MRD positivity, like the ALPHA3 trial from Allogene is one such study. Could you address low burden but high risk disease early as opposed to waiting for a rainier day where you have overt high burden disease? So that's one setting, MRD for patient selection. The other is to learn from our myeloma colleagues and develop the burden of evidence for use of these biomarkers for drug approval and accelerating drug approval for endpoints of clinical trials. And that requires more evidence for the regulatory bodies to accept them across different lines of therapy, modalities of therapy, patient populations. And it's sort of a chicken or egg problem there, where unfortunately we don't have a lot of positive clinical trials where we have a conventional primary endpoint that's led to drug approval to then go back and say, okay, would MRD have done as well early? You need a half dozen or more such trials to say, yeah, I could have gotten this answer more quickly to meet these Prentice criteria that we all hope to accomplish. But with time, I think we will. And I hope we can do what myeloma has done in lymphomas.
Yeah, I think that point you make is you need trials where there's been a separation of the curves to be able to predict or to look at how you could predict that separation. So that is an interesting point. So
Can I add
David,
one thing, Eddie?
Yeah, you go.
Yeah, I'll if I can add one, like a second and a half, a 2.5 bullet point to Ash's great list there. I think, there's a lot of data on diagnosis to treatment interval being an adverse risk factor in DLBCL and other aggressive malignancies. Many biomarker-driven randomized trials, or even non-randomized trials, but including randomized trials in DLBCL, have often given patients generic cycle ones of therapy, like everybody gets R-CHOP, and then if the biomarker comes back 3 weeks later with a certain result, you get treatment X versus Y. A lot of that, process is due to the fact that getting archival FFPE tissue from one place to another place, extracting DNA, QCing the DNA, and then running the assay and reporting it out takes a lot of time. But if I see a patient in the clinic with new DLBCL and I know they have DLBCL, I do envision a time where, maybe just a few years from now, that patient gets their disease profiled by ctDNA at baseline. And by the time they haven't had a PET yet and I need to arrange a PET scan, it may be back in 5 to 10 business days. And that's the time frame when patients would be starting treatment without such a biomarker. So it's not really slowing anything down. And so I do envision maybe not the first use of ctDNA in DLBCL. I think MRD testing post-treatment is going to be the first use, but soon enough an era where we don't need patients scant archivals, often exhausted biopsies from baseline in order to rationally pick therapies for them. We can use a plasma-based biomarker that you can draw the day they show up to clinic for the first time, and it's back by the day you would have started treatment anyway.
Just building on that, Ash, how far are those sorts of turnaround times away from reality?
Well, so these real-time clinical trials, like the ALPHA3 trial, has required that the test come back within 1 to 2 weeks of a blood draw. So they had no problem doing that. But about a week is, I think, a goal, trying to get it to about a week. And of course, there are many clinical diagnostics that perform in that week time frame, the Guardant assay, the Natera assay. So I think these are all feasible with efficient operations at scale. Yeah, so that I think is reasonable. And as the sequencing machines get faster, maybe even faster.
So David, to just finish off with, I wanted to ask you what trials you're most excited about. Ash has obviously hinted at a few that utilize or that collect data on ctDNA in terms of where you think we're headed next with ctDNA.
Yeah, so just to give more details on the ALPHA3 study that Ash mentioned, this is, I believe, a registrational phase 3 study where patients receiving standard of care frontline DLBCL treatment, not transformed DLBCL, but de novo DLBCL, patients get their tumor tissue profiled when they're towards often the latter half or latter third of their induction therapy. And if their end of treatment PET shows a CR or sort of observable PR in those very, very borderline cases, or maybe your SUV max is now 4.0 and the liver mean is 3.5, those patients get phased-seq tested, and MRD positive patients are randomized to close observation versus an off-the-shelf CAR T product. MRD undetectable patients come off the study basically and are cared for by the physician as they'd otherwise see fit. So that's obviously very exciting, and I don't know exactly when the readouts will be, but is really, I think, fantastic. There's also, I believe it's the Swiss group is doing a study where patients get baseline ctDNA-based molecular testing, and if they're of the MYD88 mutated fashion or the MCD subtype, they get R-CHOP plus acalabrutinib off the back. Otherwise, the other patients just get R-CHOP. They have MRD and PET assessment post-cycle 2, and their subsequent care is dictated by their response to therapy, where PRs add acalabrutinib, and if you're undetectable MRD at an interim standpoint, you might only get 4 cycles of chemotherapy and then 2 cycles of rituximab. So that should be really excited. I don't believe it's registrational in any context, but as far as the principles go, is really going to push the field forward.
Yeah, I think as we've all talked about, there are already patients we're over-treating, and it would be great to be able to use a biomarker like ctDNA to try and de-escalate treatment for patients who might already be cured. But we have to...
Those trials as well, Eddie. There is a trial at Columbia that Jeff Chung is leading for older patients to abbreviate therapy based on MRD negativity. And then there's a Hodgkin study that Ryan Lynch is leading, a multi-institutional, I believe, single-arm or two-arm study of de-escalating S1826 style therapy based on ctDNA by abbreviating. So there are some of those. The drug companies are less interested in those trials, of course, so we'll need smart academics to come up with good ideas for how to do that, because I agree, just like we're using scans too often, we're using drugs probably at times where we might not need them. So can ctDNA help us?
Yeah, I mean, especially in contexts where PET might be even less reliable than the data that David cited in DLBCL, such as with immunotherapies. Unfortunately, we have to wrap there. I'm sure we could, all of us could talk about ctDNA for much longer, but thank you both so much for joining us, and we look forward to having you back on the podcast soon.
Thank you. Thank you, guys.
Thanks, guys.
Thank you. Thank you.
Thank you. Take care.